Good afternoon, everyone. Thank you for joining us for our NAT webinar in the series Safe Blood Fridays. Today, we have with us our guest speaker, Dr. Purnima Rao ma'am. She is a senior consultant at Sahyadri Multi-Speciality Hospital, Pune, with more than 35 years of experience in the field of transfusion medicine. Ma'am is a technical expert on FDA's panel and is a member of scientific committee at State Blood Transfusion Council. She is also the secretary of Indian Society of Blood Transfusion and Immunohematology, Maharashtra chapter. Dr. Purnima ma'am is a pioneer to start blood banks in 1988, leukoreduction in 1995, and gel technology for immunological studies in 1996. She has authored many scientific papers and received many awards in her illustrious career. Some of her notable achievements include the N.R. Batra Award in 1984, Dr. J.C. Patel Award in 1986, PCMC Puraskar in 1997, and Corona Warrior Award in 2020. She has recently received the Lifetime Achievement Award in 2022. We welcome you, ma'am.
Thank you, Deepti, for your kind words. I think I would like to thank first at the onset my lab for inviting me to be a speaker today. I would be talking on a significant point that of awareness and NAT testing used antiseptics to control infection during transfusion. In 1915, the first known case of syphilis through blood transfusion was reported by Fordyce. In 1943, Beeson gave us a classic description of transfusion-transmitted hepatitis. In the year 1945, 33 cases of hepatitis B were screened. This infection was through plasma and blood transfusion. Hence, there was a big chaos everywhere globally. The second story of preventing TTI is transfusion medicine holds a prime importance in medical management of diverse clinical conditions, and prevention of transfusion-transmitted infections had become a major area of interest for transfusion medicine fraternity. The most important TTIs are HIV, HBsAg, and HCV respectively, which we all know. And over past 50 to 60 years, all scientists have been coming up with various strategies to prevent this infection. Still, blood bankers are not able to give 100% safe blood. But it is our moral responsibility to adopt strategies to make this as safe as possible. We all know that globally in 1971, hepatitis B surface antigen testing was done on the donated blood. In 81, first aid immunodeficiency virus case was reported. In 84, we came to know that in A7 hepatitis B core antibody with ALT in 92, HIV 1 and 2 was implemented by the government. In 96, P24 antigen testing was being done on donated blood. In 1998, HCV Look Back campaign had been started as people were already started getting exposure towards HCV virus through blood transfusion. In 99, blood bankers started implementing nucleic acid and amplification test. In 2002, NAT testing for HIV and HCV was licensed by FDA in USA. In 2014, US FDA also approved pathogen reduction system for platelets. And in 20, US FDA had approved pathogen reduction system for plasma. We have seen that there is limitation of screen limitation, though when the new technologies had not come. And due to it, 1,250 patients were infected with AIDS, out of which 273 patients were dead. And there was a big case filed against the clinician in abroad. And he was held responsible because they said, though he knew that the units were contaminated, still the transfusion was given in order to save the patient, which was not logical. It doesn't prove to be logical what they say. The government of India made mandate regarding testing of all donated blood for HIV, HBsAg, HCV, malaria, and syphilis. All blood banks are governed by FDA, as we all know in India, according to which blood tested non-reactive for the above infections can be transfused to the patient. In 1989, HIV testing was made mandatory for blood banks in India. In 99, hepatitis B surface antigen, malaria, and syphilis was made mandatory. In 2001, hepatitis C virus and test for antibody to hepatitis C was made mandatory by FDA. The outcome of not adopting newer technologies in India resulted in what? So many patients had become positive for HIV, HBsAg, HCV, and it was a big headache for the blood bankers. How do we control? We had to catch a forehead like this and said, how do we control such infection? And we need to pay, at the same time, we need to save patients' life. What should we do? Now, this comes to the thought of window period. Now, what is latent period? It is the time gap between the person getting infected and the infectious, he becomes infectious. What is incubation period? It is the time between the individual get infected and the first symptoms is seen. And what do you mean by window period? It is the person who's getting infection and the test which gives us positive result for antibody screening. Now, antibody positivity is seen at a different lag of time, like for rapid test, for ELISA test, for chemiluminescence, and definitely for nucleic acid testing. It is much lesser compared to all these technologies. Now, what comes the second thought? In India, it was very difficult to implement such a costly technology. So what comes next? The donor education comes next. The pre-donation information, post-donation, pre-donation counseling, donor history questionnaire, donors awareness has to be done, because not always it is ideally, especially the donors are well educated or aware of what they are asked for. They don't want to do self-deferral in when they are in the group. And non-voluntary replacement donors, you don't know how risky they can be. And the donor is coming to you, he will think, oh, what next question they're going to ask me? Then the donor, if he see the questionnaire, such a lengthy questionnaire, what he will say? I'm fed up with your documents if one tries to do counseling of his personal life. Though pleasant professional staff is there to ask him the questions, still he may get angry, he may kick out the document, and he may not come back to donate the blood also to us. So testing of blood in India for HIV, HBsAg, HCV was done either by a rapid test, initially where ELISA was not available, which is less sensitive. Subjective variation is there, no automation, manual intervention is there, a lot of errors can take place, not allowed by FDA, and it does not detect the donor in window period of chronic cases. ELISA and chemiluminescence, CLIA, and enzyme link immunoassay, it has better sensitivity, it can be automated, no subjective variations significantly, used in most of the blood banks all over in India. It reduces the window period and chronic cases. Why? Now here, what is crucial for us? It is the window period. How do we catch that? It is being noted that since in 2014, there were positivity rate of 59%, but in 2018, it was 71%, which has still increased as of now till today. Now, what is the solution? The major pathogen reduction method currently available for plasma involves solvent detergent, methylene blue, ametocillin or riboflavin, which is based on photochemical process. PRT offers a paradigm of target testing, as these allow for global treatment of blood products. hence rendering them safe from spreading the infection by making the pathogens incapable of replication. While the individual PRTs vary, as it has key limitation, that is the absence of technology of red cell and whole blood, and it is very, very expensive pathogen reduction technology. So what comes next? There was risk-based decision making and increasingly recognized as key to support national policy makers who are concerned with the implementation of safe intervention, especially to address the emerging infection threats which are coming day by day and the newer technology opportunities. There is an urgent need for practical decision support tool, especially in low and middle income countries. WHO has supported for the development of such tool for blood safety very, very significantly. The tool enables the users to perform both quantitative multi-criteria decision assessment and a novel step-by-step qualitative assessment. We all know that when genetic material is there, what will be detected first? The genomic material appears first, we all know that, much before the protein and antibodies which we are detecting now from the blood. The genomic material can be amplified by what technology? By PCR, non-antigenic protein it is, which will still reduce the window period compared to the previous technology. Now, what is nucleic acid testing? Nucleic acid test or nucleic acid amplification test. It is a technique to detect a particular nucleic acid, virus, or bacteria which acts as a pathogen in the blood, tissue, urine, etc. Since it is looking for DNA or RNA, it detects at a significantly early stage. Since it involves a step of amplification, even a micro quantity, a very, very low quantity of virus or pathogen which is there, it can be detected. Tackling window period is going to be very crucial because we are going to pick up the virus between the day 5 and 15. We know the current scenario in our country, only 4% of people are doing NAT testing. Whereas our vision is to make 100%. We all blood bankers should go for NAT testing without fail. Now, how does it play a role? Since 1990s, use of nucleic acid amplification test for screening of pathogens has become routine in most of the countries worldwide. For HIV and HIV-2, hepatitis C, hepatitis B virus. However, NAT is not done routinely in India. Why? It needs a high equipment capital, high cost to set up the NAT screening lab, high running cost due to imported reagents and kits, fragment blood banking system in India. It is not feasible for small blood banks to do this test. Many small blood banks with lower workload are seen in our country. Patient pressure group not very strong because this was expected from the patient who are taking blood from us, like thalassemia, hemophilia, who are continuously exposed to the blood. But poor people, they are only happy if they get the blood. They are not knowing what does this nucleic acid test means. Was no India specific solution until 2 to 3 years ago. NAT experts had simplified the NAT lab for blood centers for all of us. Why? Just look at this. They are already approved by CDSCO. It is based most on sensitive RT probes, which increases the specificity of PCR. Individual donor means it is specific like RT-PCR, and it has sensitivity for individual donor testing, like ID-NAT testing, what we call as. Single tube format is there. Limit of detection is there. It can differentiate between HIV, HBV, and HCV. It has been validated with 2 international standards. Field trials have been done on more than 150,000 samples till today. The turnaround time is 2 to 5 hours. Evaluated and validated at leading government references. It has internal positives, endogenous control to check for extraction and efficacy and PCR inhibitors. It is a fully automated system enclosed from nucleic acid extraction to plate preparation. As I have already said in my previous this, a central idea. It is a fully automated system. It has a robotic system. It is easy to use, user-friendly. It is multiplexing. Optimum set of controls are there, which will rule out all the false negativities. Simple operation. It is a user-friendly. It has a software, hence it is very simple to use. The technology is faster. We can process the samples in 2 to 5 hours. And regulatory compliances means CDSCO has approved this technology. This is the lab which we have established, means it has been established in Sahyadri Hospital. This technology can take the load of 15 unit collection to 800 unit of collection in big blood banks also. It has sensitivity of RT-PCR with specificity of ID-NAT, which I have already said, at rates most economical than the existing technology what we have now. Now it is a time for all of us. Yes, it is the need of an hour to do NAT testing for every unit that we collect in our blood bank. As I have said, what is required for NAT testing? Infrastructure, special AC rooms, special equipment, special reagents, and special trained staff. If you try to outsource, I do agree that every blood bank cannot start NAT testing. But if there is a centrally placed NAT lab is there of theirs, we are ready. As Sahyadri Hospital is ready to get ourselves outsourced, because outsourcing is very cheaper for us. We don't need any infrastructure. There is no need of FDA approval. No additional technician is required. The TAT time is maintained. No stress for discriminatory samples because the headache is taken by the lab who processes for us. Optimum utility of the equipment where it has been kept. Centralized facility of testing will benefit maximum blood centers at a cost-effective rate. Initially, even at our hospital, we were outsourcing 50 to 60% since last 3 years. It was difficulty to maintain the inventory of NAT and not NAT blood. Issue of NAT and non-NAT blood to the patients was also being done because in emergency, you cannot wait for anything. Whatever is available, the blood bankers issue that. Objection from consultants and relatives were there because there is difference in charges also for NAT and non-NAT. So a lot of controversies are always there, and a lot of controversy between the consultant and blood centers also take place regarding the seroconversion, especially in multi-transfuse cases. Considering all the above journey, it made us to go for 100% NAT since Jan 2022. We made it mandatory across all our branches. In the beginning, there were issues regarding service charges between relatives and consultants, but which got resolved when the relatives understood how safe it is to get a NAT tested blood because their patient is very, very safe, and post-transfusion problems will never be there with the patient, likely to never be there for the patient. But we are able to settle the things in 2 to 3 weeks. Now we are having very good peace of mind by issuing 100% NAT blood to all our patients. It was peaceful for us. This is the lab what we had, and more than 4,000 samples have been screened, but one HIV seronegative was found to be by NAT reactive. The viral load was there and it was confirmed positive, though the chemi value was hardly any antibodies could be detected. So this fellow was definitely in a window period. What is the take-home message by me? Let us march towards 100% voluntary collection of repeat donors so that the NAT testing, even if we are doing, still then some hitch is there in the mind that 1 to 5 days window period we are not catching. What if somebody is in that day? So if we take repeat donors, that thought will also not come to our mind. If 100% NAT tested blood mandate is done, then it is 100 definitely going to be cost effective for us. Like initially the ELISA was costing us 600 rupees. Now which has come down to hardly in 150 rupees, you get all the ELISA screening reagents and you can perform the test. In the same way, even NAT test can be performed and the cost will 100% going to be less. Let us march towards closer to 0 or 0% risk blood transfusion and be the world leaders for transfusing safe blood to our patients. Thank you for patient listening, and I would like to thank my lab for inviting me once again to take a topic of the crucial point in blood transfusion services. Thank you.
Thank you, ma'am. Thank you for highlighting the importance of NAT testing. I would request if anybody has any questions, they could mention it in the Q&A box. We can take few questions and then ma'am is here, ma'am could answer those questions. I would request everybody to please put down their questions in the Q&A box. Okay. Ma'am, we have one question. Mini pool NAT is better or NAT spot?
You want to find out whether mini pool, one should go for mini pool or ID NAT. I think that must be the question.
Okay.
Yeah.
Ma'am, there's one more question. Are there any steps taken by clinicians or doctors to make NAT testing mandatory in India? And what does WHO say regarding this?
At this moment, I think we need to educate our clinicians and consultants also. You try to go and meet them personally, try to convince them. You tell them that it is not the safety of the patient alone. You people are indulging with the patient. Suppose the patient is taken for surgery, and if any window periods blood is given to the patient, if the gloves get torn or something, if the doctor is exposed to the blood, what is his safety? Try to think for your safety, patient safety, institute safety, and definitely the safety of the blood bank. We need not face the medical legal cases. We need not give any penalty for transfusing positive blood. It is better we are as safe as possible in transfusion services. It is our duty to convince our consultants and treating doctors. How did we request them to go for component therapy? In the same way, those efforts need to be put for NAT testing also.
And there's also one more question asking the advantages of in-house NAT testing.
That is, see, advantages means you have to spend a lot. You need an infrastructure. You need a staff. It is a big headache. Better outsource it now. You send the samples will be processed. At a speculated time, you'll get the reports. You get your bags for issue of blood, and there is no headache for additional staff to be taken. I think that should be better. And in the centralized lab also, the company support is also very good over there. The engineers are there, very much there to help us out. Instead of starting at every blood bank, it is better one centralized lab is there. We send a sample and all the samples are processed there.
Also, I would just like to mention that with the system that Dr. Purnima ma'am mentioned, the compact Excel system, as well as a compact DX system, even the minimum samples can be processed in the automated system. So you need not have a more number of samples and then only you can process. But even like minimum samples, such as one sample to maximum of 32 samples can be processed using the automated system.
Any more questions?
They have mentioned why NAT blood is not made compulsory by law in every municipal corporation area.
Yeah, that is what, here everybody is. Now, FDA will see in broad spectrum, even in rural area, in villages where there are small storage centers. If some government blood bank is there, it is difficult for them. It looks like if there's no centralized lab. Actually, government has to make it mandatory. How Rajasthan government has made it mandatory that every unit that is processed is going to be NAT tested. So that way the government decision has to be there. Maharashtra government has to take the decision. Every unit that is going to be transfused to a state patient should be NAT tested. We had approached to the ministry, but no response from there. It is very sad. Let us all go so that we can do it. We can do best for the society.
That is where, ma'am, awareness is required, and
Right.
we need to highlight on why molecular NAT testing is important for blood before blood transfusion, any blood transfusion.
Yeah, that's what I said. We need to
Yes.
educate our clinicians and consultants. What we have done, we have put flexes all over in our hospital, the benefits of NAT testing. We have educated and everybody agreed for that. And now they tell us we want only NAT tested blood. So we are very happy.
Correct.
Our efforts have been fruitful.
Yes. Thank you. Thank you so much, ma'am. And thank you for your guidance and highlighting the importance of NAT testing. We really thank you for your valuable time and for explaining the importance of NAT testing to the audience. I would request everybody, if at all there's any questions. We have limitation of time. So what we can do is we can get back to you with the queries or any details that is required. And we'll share the details of the kit as well as our system also on the mail.
Yeah.
Okay. Thank you. Thank you so much, ma'am.
Yeah, it's my pleasure. Thank you.
Thank you.